Good evening, everyone. So welcome to the second session of our series on professionalism. So the aim of this series is to clarify to non-professionals especially, what is the meaning of a professional with a capital P, as opposed to the common use of somebody being a professional who just does their work to a very high standard. Furthermore, being hosted by an Orthodox synagogue, in other words, Spanish and Portuguese synagogue, as well as Haimovici, we asked our speakers to add an extra layer to their talk, which is what are the implications of halacha and Jewish ethics on their profession and on their professionalism. Most of the speakers in the series, but not all, are members of the Spanish and Portuguese or Haimovici congregations, and we certainly appreciate the presence of guests who are not members of the synagogue. Each speaker will speak for about 15 to 20 minutes, and there will be a question period of about 15 minutes at the end that will be moderated by myself. So our first speaker is Professor James Archibald. He has degrees from McGill, University of Montreal, and Université de Lille in France. He has teaching and research expertise in the areas of management, business, communication, and translation studies. He's a professor in the Department of Language and Intercultural Communication at McGill University and a member of the Office des Professions du Québec. And I'll leave it to Professor Archibald to give you the title of his talk and show his slides. So I'm going to make him co-host. Okay, you are now co-host, so please go ahead. Thank you.
So what I wanted to speak to you today is one of the issues that I've been working on for a while in medical assistance in dying legislation at home and abroad. So I won't go into a lot of details because it's an extremely complicated issue, but I wanted to give you some of the highlights and to start out with, to point out that a lot of the halakhic issues that we're dealing with can be traced back to the work of Maimonides. And so I think it's important to point that out, given the context that we're working in. And in addition to the fact that many doctors have Maimonides' prayer on the wall of their offices to remind them of those obligations. So what I'd like to do is to briefly look at Carter versus Canada, to look at the Baudouin decision, Truchon and Gladue against the versus the Solicitor General of Canada and Quebec's Attorney General to enable medical assistance in dying. I'd like to, because one of the issues we wanted to look at was to look at reality. So I'd like to look at actually the scene when one of these persons actually met his end. Then I'd like to look at some other jurisdictions where this issue has played itself out, and specifically in Belgium and the Netherlands, Switzerland, the United States. And then to look at new legislation, one which was just adopted in Canada after a long, arduous effort by MAiD and company in order to get something done, and a law which is just literally adopted in Spain by the Cortes in Spain, which legalizes euthanasia in that country. Then to follow up on the discussion that we had last week to see the difference between the minimalist and maximalist approaches to these questions, and ask ourselves a question at the end, is compostability a way out of this dilemma, etc. In the appendix, I provided a bibliography for someone who'd like to do some extra reading, and also a copy of the prayer from Maimonides. So as a specialist in translation, one of the first things that we always like to do is we like to be able to define terms, to know exactly what things mean. And this is a relatively difficult thing to do because normally in legislation in Canada and in other countries, the laws usually contain a section where they define the terms that are used in the law. And one of the strange things with the Act respecting the end-of-life care and the Federal Act modifying the criminal code, there is no clear definition of what we mean by medical assistance in dying. The Quebec Act gives us some sense of what the purpose, the overall purpose of the Act is. And we can deduce from that that medical assistance in dying has to focus on care of patients. It has to focus also on the respect to the dignity of the patients that were involved. That's part of the issue of rights that have to be respected. Then the patients have to be autonomous in terms of their decision-making ability. So that means that someone cannot ask for medical assistance in dying unless they are autonomous, unless they are immense competence. So it's clear that there are lots of rights involved here, and that the purpose of the legislation is to, as it's stated in the preamble, to prevent suffering and to provide some relief from suffering, which is basically intolerable suffering at the end of life. And the Act also provides a clear framework for the actual process and how these directives are actually drafted and approved and put into effect. So the preamble of the Quebec Act finishes by saying, and I quote, medical aid in dying means care consisting in the administration by a physician of medications or substances to an end-of-life patient at the patient's request in order to relieve their suffering by hastening death, not necessarily by causing death, but by hastening death, creating conditions. The Spanish law, which was just adopted in March, so it's very recent, the ink is hardly dry, is much more precise as far as this is concerned, in the sense that at the beginning of the law in Spain, which is referred to, by the way, as a fundamental law. In other words, it is very much linked with fundamental rights. And they define it as follows. You can read on the slide, but I just wanted to highlight some of the terms which come up here. They use the term euthanasia. The term euthanasia is not used in the Canadian legislation, nor in the Quebec legislation, although you do find it in some European legislation. Euthanasia is defined as a deliberate act. In other words, there's an intent behind it. And in legal terms, that's extremely important to define what is the intent. Moreover, will on the part of a person who is suffering and who wishes to end his or her life, etc. So the Act then in Spain distinguishes between what we refer to as active euthanasia and passive euthanasia. I think that's an extremely important distinction, because in the Canadian legislation, the assistance or the medical assistance in dying is in fact an act, is determined as a medical act. And the Spanish law goes on to talk about passive euthanasia. And if I may, I'd just like to read that one paragraph because it's extremely important. So we designate as passive euthanasia non-adoption of life-prolonging treatments or the interruption of life-prolonging treatments. So that could be interpreted to mean that do not resuscitate orders could be perceived as passive euthanasia. However, the Act goes on in its definitional part to conclude that, and I quote, palliative care has been excluded from the bioethical and criminal legal concept of euthanasia. So therefore, if someone happens to die because of treatment during a palliative care situation, the person could not be charged with a criminal offense. So that's important to do that. If we go back to the Canadian situation and we look at the Carter versus Canada decision from the Supreme Court, and then at Baudouin's decision with regard to Truchon and Gladue, the situation is a little bit different in that the patient must be close to a natural death, and it must be reasonably foreseeable in order for a person to have access to medical assistance dying. And in the initial pass at this, prolonged illnesses and disabilities were excluded. And that's the reason why Truchon and Gladue appealed the case to the Quebec Superior Court. So assisting such persons, called assisted suicide, remained a criminal offense in Canada. And however, following the Baudouin decision in the Quebec Superior Court, temporary authorization for medical assistance in dying for a person who is not terminally ill, but who's suffering from a disability, that was allowed. And furthermore, Baudouin told the Minister of Justice in Canada that the criminal code had to be revised, and that the criminal code and the laws of Canada had to be harmonized with the laws of the Quebec legislature. So that meant that he had to start out by doing this whole revision process, which took him forever. There were delays and delays and delays. And I must say that I've been extremely vocal in arguing with him on that particular instance. So if I go back to Truchon, let's just look at what happened in this particular case. So Truchon was suffering from a neurodegenerative disease, and he was not terminally ill, but he was suffering. And he also was, this was happening at the beginning of the pandemic. And he was in the CHSLD Poligny Léger, and he foresaw that it was going to be an absolute nightmare for him to live through this. It would increase his suffering, and he feared the loss of his human dignity. And under the Charter of Rights, he has a right to be treated with dignity. So he filled out the proper applications. They were approved. The deadline was set, but he couldn't wait until the end of the deadline, and he wanted to move more quickly. And during that particular scene, when he passed away, the stakeholders are there in the room with him. That included the attending physician, a nurse practitioner, a pharmacist or a pharmacist assistant who has to provide the medication necessary. And the attending physician, of course, has to make sure that he has actually given informed consent before the process actually starts. So he is put on a drip. He's given a medication in order to make him relaxed, basically a simple sedative. A second medication is administered in order to relax his muscular system. And then the third medication is administered, which is Gehr, which actually causes the organs to cease operation. This is a problem at this particular point in time because the same medication was used in COVID cases in order to to put people into induced comas. So there was a problem about the availability of the medication itself. At any rate, the operation went on according to plan, and Mr. Truchon passed away in front of his witnesses, and he was relieved from his suffering at that point in time. The question which one might ask, which Benji Friedman might have asked, is this what he called an ideal death? I don't have answers to all these questions. That gives you a vision of what happened here locally. Other jurisdictions have dealt with this issue for a certain period of time. Belgium has a law which allows for assisted suicide, and it's interesting to look at the terminology. Luxembourg has a law which allows euthanasia and helps people commit suicide. The Netherlands has probably the most pervasive code, which is their euthanasia code, which was recently modified in order to allow for advanced directives. And that's in fact what is being discussed right now in the Parliament of Canada and the National Assembly in Quebec, as to whether or not advanced directives for people who are suffering from debilitative diseases should be allowed. The Swiss code also allows for advanced directives referred to in French as directives anticipées. And although the actual intervention in terms of assistance or aid or help in dying is not allowed in American states, there are pieces of legislation which do allow some form of intervention. The new legislation, which is adopted, now opens up the access to medically assisted suicide, if you will, to people who are suffering from neurodegenerative diseases. And currently we're discussing the possibility of having directives for people who feel that they may not be able to give an informed consent at a later point in their lives. So the criminal code was also amended in order to do that. And I just mentioned, of course, the fundamental law adopted in Spain, which allows people to perform euthanasia, either active or passive euthanasia. So for practicing professionals, this obviously for nurses, doctors, nurse practitioners who now have increased powers in Canada and Quebec, it poses a certain number of dilemmas. So I don't have answers to these dilemmas, but there are certain questions I think which should be asked. And ad seriatim, how does one manage a very complex medical act? Because whether it's called euthanasia or assisted suicide or medical aid in dying, it's still defined as a medical act. And how does this involve shared responsibilities of many stakeholders? And that means physicians, nurses, nurse practitioners, social workers who have to deal with the families, the institutional administrators like hospital administrators, social workers, and medical ethicists. That's why I mentioned Benji Friedman just a few moments ago, because he was the medical ethicist at the Jewish General Hospital. Secondly, where's the prime responsibility for the act of assisting near-death patients or caring for gosesim, as we say in Hebrew, of respecting living wills and following DNR directives? What do you do in cases like this? Are healthcare professionals bound by oath, shavua, to bring no harm to their patients and to refrain from participating in assisted suicide, or, to quote Maimonides, lead God's creatures to their death, which means that there's some issue of intentionality here. which poses a philosophical problem as far as Maimonides was concerned. Where does one draw the line between freedom of conscience and the deontological responsibility? For instance, in a hospital setting, one has the responsibility of making sure that the system is in place in order for people to be able to exercise their rights. But on the other hand, practicing professionals who don't feel comfortable with this situation can exercise their freedom of conscience and not participate actively in what was defined by the Spanish Code as active euthanasia. So where do the minimalist ethics and the maximalist vision intersect, as we mentioned before? So on a personal, people make their own personal decisions, but on a societal basis, from the maximalist point of view, institutions have to make sure that the rights of all people are respected. And since people do have access to medical assistance in dying, therefore the institutions have to provide that service in the type of state that we live in. And finally, is there a possible societal consensus, or must we continue to live in a perpetual dissensus? That is basically what Ruth Haimovici points out in her work, where very often these types of things, we have difficulty arriving at some sort of a consensus because there is so many radically opposed views. And you can imagine that with this particular issue, there are a lot of radically opposed views. So the question that I ask at the end, is compossibility something that we can look at? Compossibility is a philosophical concept developed by Leibniz, by Spinoza, discussed further by Bertrand Russell and many others, where you're looking at two options for action which seem to be diametrically opposed, but how can you actually make these things work together in order to move forward from a social point of view? So, can opposite ends of the moral and ethical spectrum be reconciled? That's something which people have to debate personally and from an institutional point of view. Can society arrive at more universally understandable definitions of patients' rights, their ethical and moral responsibilities, and with regard to this professional act as a reserved area of practice? So if we say that medical assistance in dying or active or passive euthanasia is a medical act, is it a reserved area of practice, and who can practice? That's where, in terms of, for instance, the College of Physicians in Quebec or the Office de Profession, there is going to be a definitional problem as far as defining the actual professional practice. So there is a need to rise above the contradiction. I borrowed that from the work of Maimonides because basically from a philosophical point of view, Maimonides says that there are contradictions in medical treatment. But what we have to do is we have to decide, as in a Talmudic discussion where you have a pilpul, where there's one side arguing against another side, we have to find a way out because society has to continue and we have to continue to work together. And from the medical point of view, from his point of view of medical ethics, it's important that the well-being of the patient be taken into consideration. And the term which Maimonides uses for this is the medical professional is a chômeur. He has to watch over the patient, not only the patient in life, but the patient who is approaching death, and to do nothing to harm that patient. So the basic question, when you look at all the different arguments in this particular issue, is there room for compossibility in the end? Can we resolve this in order to move forward without continually living in a world of dissensus? So that's the question which I leave you with. I don't have an answer. And I've provided you, if you want, I think Ronnie will make this available to everyone with a bibliography with some readings which you could look into later. And I've also provided you with the prayer of Maimonides, where he provides a clear direction as to how we should act in terms of our medical ethics. So thank you very much, and hopefully we can discuss some of this during the question period.
Thank you very much, Jim. I'm sure there will be a lot of questions. It's a question of how much time we'll have for all these questions at the end of the session. So I'd like to move right along to our second speaker, a totally different subject, concentrating on just a small part of the body. Our speaker is Dr. Joshua Haimovici. Dr. Haimovici was born in Israel. In 1981, he graduated with a BA biology from Yeshiva University in New York. In 1985, he graduated from McGill with a doctor of dental surgery. Dr. Haimovici founded 2 multidisciplinary dental clinics in Montreal, one downtown in Place Bonaventure, and that was in 1985, and one in Place Vertu in 1986. He's married to Chana Devora, and they have 3 wonderful children, Yehonatan, Elior, and Tehila. And from our point of view at Chevra Shas, he has been the cantor for the past 41 years. And with that as introduction, I'd like to give the floor over to Dr. Haimovici.
Thank you very much, Ronnie. First of all, congratulations. Thank you very much, Dr. Archibald and Dr. Gehr, for a wonderful program on this Victoria Day weekend. And for that, coming after assisted death and suicide, that's how people think about a dentist coming to a dental appointment. Now I see the reason why you put me after Jim. So I don't know where to start now. Whoop. In any event, I was asked very humbly to accept to talk about what I do as a professional, and relate that to halacha, to our Jewish way of life. And definition of a professional for me is never having to do it as an amateur. If we go up on the teva as a cantor and you're not feeling well, that's not the problem of the tzibur, of the congregation. You go up there and give your best. And that's the way I live my life, and that's the way I'd like to give it on to my children as well. So as you said, my educational life started before Bar Ilan, actually, before Hebrew University at Talmud Torah and Herzliya High School, and then Bar Ilan University, Hebrew University of Jerusalem, where I studied biology, and I received a degree at YU Yeshiva University in 1981. Decided to go to McGill after being accepted there and other places. In any event, I was lucky enough to enter a profession that is fantastic, has done me well, and served hopefully the congregation and others, allowing me to do what I like to do in life. I have 2 partners in what I do, God and my wife, Chana Devora. And they allow me to do what I do. I do it. I chose dentistry. I chose dentistry because it's both a science and an art. I thought more an art in the search for beauty. I now know that beauty depends on the science and science of engineering that Dr. Gehr knows about in terms of, I'm sure, golden proportions and formulas such as force over area is the pressure on teeth, and so on. So we learn about engineering, and definitely linguistics come together. The language, the language of, or the skill of languages and the knowledge of languages really connects people to the professional and allow the professional to gain trust. If there's no proper words selected in the discussion, sometimes the discussion can unravel and the message or the medium is lost, the message is lost. I had the good fortune of going through good schools, and since then, enter the profession through different venues in different countries, and through the Academy of General Dentistry, which is an American association, through a Congress of Implantologists later on. The profession definitely allowed me to do many, many things that I enjoy to do, and hopefully that'll show in my presentation. I do nothing without my team. You might be better than me, but you're definitely not better than my team. And so some of these young ladies have been with me for 30 years, excess of 30 years. I have associates in the office, and the young lady in the white is also a stagiaire. We also, for the past 30 years, have been involved with the schools, teach dental assistants and others. And they send the stagiaires to the office to learn what to do. We are not only a dental office. What we pride ourselves in is changing people's lives. As Dr. Archibald says, shomer, well, we definitely preserve the quality of life. And as it says here, we change people's smiles and help them gain confidence, which is a big thing nowadays, confidence. A lot of people on antidepressants and need to feel good about themselves. Their total health. And that starts also with the teeth and health by using the latest technology. So I thank Hashem for giving me the choice of entering a profession that allows me to do what I love to do. And as I do it as a dentist, I'm always guided on the highway of our profession by two anchors. The one on the right, the Shulchan Aruch, and the one on the left, the guide of the Code of Ethics, the Order of Dentists Code of Ethics, what to do. And when I was asked to speak about what I do, I really didn't want to enter this domain of talking on Zoom to people I don't see. I'm not comfortable doing it, to tell you the truth. And I didn't know what to talk about. The truth is, there's so many halachic implications in a private dental office, from Shabbat, schedules, holidays, fast days, prayer times, mincha, employer-employee implications, issues, interest charges on overdue accounts. I asked the rabbi several times what to do. We all have a rabbi and a guide. But the main thing is to always do good with the halacha, with the Torah way of life, and the code of ethics given to us by our profession. So we do a lot of things, and the decision to treat broken, decayed, trauma cases, the one in the broken tooth on the upper left, a boy hit him in the back of the head, took off half a tooth, and we rehabilitated that, all the way from broken, decayed to congenitally missing issues to issues of neglect. And the one on the bottom right is neglect, which I've been able to allow this person to have a sense of being human, because he wouldn't be able to afford to rehabilitate himself properly. And for the last 20 years, this is the way he is maintained. Very, very comfortably. Actually, he comes from Ontario, drives over an hour and a half to the office. So we do a lot of things. And as we do them, and as I do them, sometimes we're, basically me, I'm in front of road signs that I have to decide on the spot what to do. Just like I was stopped on Fleet, I had to read on the spot, Johnny on the spot, am I allowed to turn left between 7:30 and 7:45 with the cars honking me in the back? To move on, we have to know what to do. And these decisions, these professionals and halachic decisions, have to keep us safe and preserve the life, the quality of life, like Dr. Archibald said, of our patients, not only to be a shomer, but to encourage them for better health. Those decisions, professionally and halachically, have to be done sometimes on the spot. Sometimes they can come back, people can come back as a consultation later on. But the guides, the anchors, as I said, the Shulchan Aruch and the Code of Ethics are always on top of our mind. So what is the halachic perspective of a doctor's obligation. And I say a doctor's obligation because a dentist is a doctor. We treat the whole person. We start with the mouth. And there are definitely implications on heart disease and diabetes and so on. So without getting into that, because the time is short, Leviticus, Vayikra says, and you shall not stand aside while your fellow's blood is shed. This is in life or death situations. You shall love your fellow as yourself and definitely preserve life. In Deuteronomy, it says, and so shall you do for any lost article of your brother. Any lost article of your brother, meaning dentition, teeth, health, any lost article of your brother that may become lost for him, you shall not hide yourself, which means you must help him. You cannot decide not to do this. As a dentist, we are in a private industry. We are private. We can decide to do certain things, certain actions or not, unlike in a hospital. But the Shulchan Aruch also continues and says, your fellow's health must be returned to him as a lost article. The mitzvah of bringing back a lost article to your brother, the doctor may be compensated and must use his body, time, and skill to return the lost health and not look away and not decide, no, I will not do this for this particular person. However, in Vayikra, Leviticus 18:5, the Torah says, you shall observe my decrees and my laws, which man shall carry out and by which he shall live, which means it's dependent on the individual person himself, if they can do so, unlike the previous talk of assisted dying in terms of a person not being able to help himself. Here, in my domain, it is mostly voluntary by the person himself, by the patient. So it says, you shall observe my decrees and my laws, which man shall carry out, by which he is responsible. The doctor is a partner, but the individual is responsible for his own health. The obligation to choose a healthy course of living starts with the individual and shall not be relegated to another. This is the implication. That's the halachic perspective. And so in summary, rabbinic law states that it's a positive mitzvah. It's a mitzvah. It's a positive commandment to A, preserve life or help preserve life, and then B, return what was lost health, and in my domain, lost dentition, lost bone, lost gum, lost teeth, lost quality of life. So the foundation of dentist-patient relationship in the halacha is an obligation. It's an obligation of a dentist to do what he does. Let's continue. What about the code of ethics? All these pictures are basically from the camera in the operatory in our office. These are all our pictures. And I'm proud of these cases because every story, every smile, behind every smile, there's a long Megillah, a long story of a person coming in and in need. In any event, dentist professional code of ethics says, a dentist may not cease treating a patient unless he has sound and reasonable grounds for doing so. And when I saw that sound and reasonable grounds, it allowed me to think, this is very subjective. So I called up the Association of Dentists and they gave me this, ABCD. What is sound and reasonable? If the patient is disrespectful, aggressive, and threatening behavior, well, we do have those. Some people can be aggressive. We can decide not to see them according to the code of ethics. Person misses appointments, does not pay fees. You make an appointment 2-3 times, the dentist can say, I'm sorry, my obligation in halacha is to treat you, but you don't allow me to treat you according to the code of ethics. I can say, find another dentist. The third one is non-compliant with clinical instructions, and this is the one I'd like to harp on tonight. Non-compliant with clinical instructions. A patient does not follow what I ask him to do. And so am I supposed to continue being a shomer for him or to give him his lost article, lost health, lost dentition? If he is non-compliant, what is my obligation in terms of the code of ethics? The code of ethics says you are not responsible, the doctor is not responsible. According to the halacha, I'm not sure. refuses to provide medical information. Some people do. They, for some reason, don't give all of their information. We choose not to see it. And the exclusion, the opportunities for a dentist to say, I will not treat you, is excluded. We cannot do that during ongoing treatment. If something was started, can't leave people hanging, or if they are in pain. We cannot say, according to the Code of Ethics, I will not continue treating you. Something very, very interesting I found. It says in the Order of Dentists bulletin, it says a dentist may never retreat a patient, which means accept a patient who was excluded from the practice for whatever reason. I don't know if a Jewish way of life is doing this, because we always have the idea of tshuva and reassessing our behavior. In any event, the foundation of dentist-patient relationship in terms of the Code of Ethics is trust. It's not an obligation, it's trust between the practitioner and the patient. So here we have a case study which I'd like to speak on today in terms of the case that I saw 3 months ago. It came in about 3 months ago. Happy patient with 2 aesthetic front crowns. The 2 front teeth, upper front teeth, are crowns that were done 5 years ago. I did those 5 years ago because he broke them. He fell on his face, broke his 2 front teeth, and they were redone. The other teeth are his natural teeth in good condition, sound for his age, patient of record. He comes in many, many years, twice a year. He has good hygiene. He's compliant with clinical recommendation. Everything is good. 14 months later, after COVID allowed him to get out of the house because he was afraid of coming to the dentist, he appears in the office like this. He was working from home, he says. He's sitting in front of a computer for 10 hours, and he has a beautiful coffee machine, gives him espresso, which he drinks 9 espresso coffees a day. And he found on social media that lemon juice is very, very good in treating or preventing COVID-19. So he does that to the max. He presses, he juices every day, not in water like the picture shows, but he squeezes pure lemon and takes it down daily. He is not symptomatic. He feels now that the masks are about to come off. It's unaesthetic. It's unappealing. He's not in any pain, but it's just not nice. It doesn't look nice. From a clinical point of view, I can go on many, many slides, but let's suffice to say that he's definitely ruined his dentition. He has loss of enamel, which is the strongest part of our body, the enamel. And the lemon juice or the citric acid is like kryptonite to Superman. There's definitely loss of enamel and teeth and dentin. And what does he want us to do? He wants me to clean the teeth and do a couple of white fillings. While cleaning the teeth, after about 40 minutes of one of the hygienists cleaning the teeth, I asked her, just finish up. It's impossible. It's impossible to clean out that dark black area on all the teeth. He needs more than that. And he is resolute. He wants just a couple of white fillings. If I would do the white fillings and do that for all the teeth that he wants, I would finish up in about 2 hours. And if he continues with the acid, with the lemon juice, he would be back in the office 5-6 months later saying whatever you did is no good, or do it again. And even if he would want me to do it again, and money, let's say with all the money in the world, and all the time in the world, doc, just do what I'd like you to do, fix me up. It wouldn't be right. I wouldn't be able to do that. Why? Because he's unwilling to stop the juicing. The insult is going to continue. So I turned to Rabbi Shakespeare and I asked, to treat or not to treat? Do I treat this person? Do I give him what he wants or not? According to the halacha, we saw that I have an obligation to restore his lost dentition. It's my obligation. He lost something, I've got to give it back to him. The Code of Ethics says he's not compliant, you don't have to. He's not compliant, he's insulting the teeth, don't do it. The girl in the front, the two pictures in the front, well, she came to me after deciding herself that drinking soda, 2 liters of soda a day, is no good for her. She's lost her quality of life. She can't smile, can't talk. She works in a medical office, and it's harming her lifestyle. So her I treated. On the bottom, there's a person who comes in with something that will destroy his teeth, breaks his teeth constantly, and the minute he took off the barbell, that's when we started restoring his broken teeth. Broken teeth due to the barbell, the broken front teeth, lower front teeth. So to treat or not to treat, on Pesach, I read Haggadah. In the Haggadah, it tells me that the month of Nisan is full of Nisim, full of miracles. We were redeemed in Nisan, we will be redeemed in Nisan in the future. And that's where I found the response, should I treat or not? The question is, why not call the month of Nisan Nisim? Nisim is a proper word to say multiples of Nes, miracles. Well, the answer is given to us by Rabbi Israel of Ruzhin when he explained a pasuk, a phrase in Exodus. Says, if you see the donkey of someone you hate crouching under its burden, would you refrain from helping him? The answer is, you shall help him. That's a commandment. That's a positive mitzvah. And Rabbi Israel of Ruzhin explains or details the word crouching, meaning rovetz. Rovetz in Hebrew, as the master linguistic in our panel will know, it's a singular action. Rovetz, he is doing it one time. He's not a ravtzan. A ravtzan, the suffix an, means that there's a repetitive occurrence. Just like we say a rakdan, a dancer, leitzan, a clown, a person who clowns around, atzan, a runner, and a sachkan, a person who plays, a player. One is not rabbinically obliged to help a repeat offender, a ravtzan. The pasuk says crouching, rovetz, not ravtzan. That helped me understand, is this person a regular occurrence problem, a repetitive occurrence problem, or a singular action? Well, he's continuing to take his juice, and he won't stop that because he's afraid of the unscientific way of treating or preventing COVID from our point of view. Therefore, he gave me the answer. The convergence of professional rabbinic ethics came to me from the donkey. So the halacha says our patient is a habitual lemon juice user, actively causing loss of his own dentition. He is responsible, as we saw in the first or second slide, that he is also responsible for his health, actively causing loss of his own dentition. There's no need for me to help him unless he stops the insult. According to the Code of Ethics, our patient is non-compliant with clinical instructions. Stop the acid, we'll be able to treat you. We can safely deny him the treatment he requests. Bottom line, the actual clinical outcome of this person after having 2 consultations, well, he came back and he says, Doc, I fully understand. I will stop. Please take care of me the way you know how. And so full mouth rehabilitation with full coverage crowns was accepted as treatment. This is where the halacha in one case scenario coincides with the Code of Ethics. I want to thank you for your attention. I will end off with a pasuk, with a phrase we say in every siddur, in every morning, shacharit. We say to God, instill understanding in our hearts, to understand and elucidate, to listen, learn, teach, safeguard, and perform, and fulfill all the words of your Torah's teaching and my addition at the Code of Ethics with love, always with love. Compassion, definitely, as the Rambam says, even though you might not have a mitzvah to treat, you do have the obligation to be compassionate and to do everything with love, just like the Kohanim, the priests, bless us with love. We, doctors, dentists, professionals, must treat our patients, must deal with our fellow human beings always with love. Thank you very much for your attention.
Thank you, Dr. Haimovici, for a wonderful talk. I wish there would be time now to speak more about it, but we must move on, and we would like to move on to our next speaker. There will be time at the end of the session for questions. So our next speaker, our third speaker, is Dr. Laurie Gottlieb, who is a professor in the Ingram School of Nursing at McGill, where she holds the Flora Madeline Shaw Chair of Nursing. She's the nurse scholar in residence at the CIU SSS Centre West of the Jewish General Hospital, and the visiting professor of leadership at the Canadian Nurses Association. She earned her RN from the Jewish General Hospital, her baccalaureate and master's degrees in nursing, and a doctorate in developmental psychology, all from McGill University. She is the developer of Strengths-Based Nursing and Healthcare, SBNH, a philosophy and value-driven approach to guide clinicians, educators, leaders, and managers and researchers. So without further ado, I'd like to hand the floor to Dr. Gottlieb, and I will be making you co-host imminently.
Okay, so thank you very much, Jim and Ronnie, for this invitation. It's been a long evening. I'm going to approach this a bit differently. I'm going to start off by situating you a little bit in my field. Everyone has had contact with the nurse, but few know what nurses actually do. So I'm going to begin there, and then I'm going to move into the code of ethics that govern our profession. And we'll talk a little bit about some of the biblical references to nurses and midwives, and move into some of the things that have shaped my thinking and my approach to nursing. That is a philosophy called strengths-based nursing that is now being adopted worldwide. Okay, so a little bit about my career. I'm going to do it very quickly. I've been in nursing for almost 60 years. It's still counting. I have worked as a clinician and as an educator from working from at all levels of nursing education, working with at the CJEP level. In fact, I started the CJEP nursing program with another 5 other people, teaching at the baccalaureate, master's, and doctorate. I've been a researcher since 1974. First, my research focused on early family development, and then evaluating different approaches to nursing and with different outcomes. And at the moment, I'm leading a very large multidisciplinary study evaluating the effects of a leadership program. And I'm also collecting COVID-19 nursing stories. I've had leadership positions, and I've engaged in many firsts, working as a nurse researcher. I developed and taught the first nursing PhD program, was editor of the Canadian Journal of Nursing Research, et cetera, et cetera. So I just want to talk and situate everyone in terms of what nursing is. So every profession has a social contract, and that's the contract that society contracts with a group of people, i.e. a profession. And in exchange for the contract, the obligations of the profession is in terms of what their role is, in terms of what they are meant to fulfill, and in exchange, society provides recognition, esteem, and also allows for regulation of the profession. So nursing social contract is promoting health, and it's helping people live their healthiest lives. It's also, when we think of health, we think of health in terms of becoming, helping individuals and families, communities develop their full capacities and capabilities and acquire the skills to cope, develop, and grow. In fact, one of my first roles was as a school nurse, and this was exactly where my focus was. Public health nurses do this, palliative care nurses, etc. The second major role of nursing is that of facilitating healing. And most of you know nurses in this role. And those are creating conditions for people to self-heal by creating healing environments. it has been mentioned that we do not heal another. It's patients and people who have the capacity and the competencies to heal themselves. And what nurses do is create those healing conditions. And we help healing through alleviating suffering. So this is a year, many of you don't know, 2020 and 2021 was designated by the World Health Organization to be the year of the nurse and the midwife. And this coincided with Florence Nightingale, the founder of modern secular nursing's 200th anniversary of her birth. So this year started off very excitingly in 2020 as a year of the nurse, and we know what happened. But this is what Nightingale said what nursing was and what nursing's role is. I won't read the whole quote because she starts talking about medicine and that medicine thinks it cures, but she said medicine doesn't do it. Neither, I'll read it. It is often thought that medicine is a curative process, and she wrote this in 1860. It is no such thing. Medicine is a surgery of function, as surgery proper is that of limbs and organs. Neither can do anything but remove obstructions. Neither can cure. Nature alone cures. And what nursing has to do in either case is to put the patient in the best condition for nature to act upon him. And so how does nurses do this? And what is the nature of nursing? It is how nurses create healing environments. And there are many types of environments that patients have. So the nurse can be the patient's environment, and the nurse acts as the patient's environment through their presence, their compassion, and their connectedness and self-care. Nurses also create safe, health-promoting and healing environments. And I was interested when Jim was talking about, end-of-life care. Nurses do this by attending to both the physical aspects of their environment. And I was thinking back of a colleague of mine, Bessie Bistis, who was the head nurse at the time of the palliative care unit at the Jewish General Hospital, and they were renovating, and she made decisions in terms of how space was going to be allocated and to ensure that there was enough space for families to be able to visit, to make sure that the way rooms were situated would be that nurses could move in and out and could really observe the patients. We know that she also focused on the noise levels and making sure that the noise was at a certain level so that patients could sleep. And just recently, I was listening to a nurse, and one of the stories she told me was how they were going into long-term care during the COVID crisis and really monitoring the ventilation and ensuring there was good and sufficient water. Nurses create conditions for healing through their presence and connecting. And there's different ways nurses connect with patients. One is their level of interaction could be at a physical. Nurses are probably one of the only, well, other than other professionals, but where there's very intimate body-to-body contact, where nurses are caring for the body, the patient's bodily needs, and providing physical comfort. That's a huge part of nursing. The psychological presence is when they are connecting mind to mind, and that's the communicating and empathy and the non-judgmental, and the therapeutic presence when they are aware of the patient's spiritual needs. Now, people often confuse nursing and medicine, and I just want to distinguish between them. Nursing can and should be complemental to medicine. It's not subordinate to medicine, it's complemental to medicine. Medicine's social contract is coming up with the right diagnosis and the right treatment. That's what medicine is charged with. In fact, I'm just reading this book on the lost art of healing, and it's all about how medicine diagnoses and treats. And once the diagnosis and treatment are done, then nurses have to create those conditions for health and healing. So patients have been given a treatment, and now enter into the phase of healing. And so patients and families need both medicine and nursing, and they benefit from both, and they especially benefit from both when medicine and nursing works together as partners and as collaborators. Now, nursing is a high stakes professional practice, and it's high stake because often nurses are the ones who are there 24/7 in terms of, especially when during hospitalization, in which patient safety is dependent on nurses being able to pick up early cues. And when they don't pick up early signs of deterioration, there's a thing called a failure to rescue. And this requires knowledge and presence and the ability to sense when patients might be deteriorating. Nurses are very much involved moment to moment in terms of making clinical reasoning and judgment in terms of what's needed. We could see that they are constantly improvising and tailoring care to that specific patient, to that particular situation, which therefore requires very knowledgeable nurses. And there's what we have seen in COVID-19, there's a difference between okay care and knowledgeable, compassionate care. Without the knowledgeable and compassionate care, patients were at risk. We know that nurses are the backbone of the healthcare system. They are with the patients 24/7. They are there constantly. In one of the stories I was told, when COVID really hit and the Jewish General Hospital converted into a COVID hospital, one of the people I was interviewing told me how it was really the nurses were manning the hospital. Without the nurses, there would have been no hospital. People were flitting in and out, but it was the nurses who were there during most of the time. Nurses outnumber physicians 7-to-1, and they're the largest healthcare workforce. And they are with patients at their most vulnerable. They are there when patients are dealing with the most difficult aspects of their situation, and when they're most frightened. Now, Gallup after Gallup poll for the last 19 years running, nurses has been ranked as the most trusted of all the professionals, and that includes lawyers, bankers, doctors, etc. And it's based, that Gallup poll ranking is based on honesty and ethics. And they enact, part of their role is to enact medical directives, but they can only enact those medical directives if they truly know that patient and they observe how the patient responds to the medical treatments, and they tailor the regime to that unique person, to that unique situation. So to practice nursing requires acquiring and using knowledge, clinical reasoning, and skilled know-how, and ethical comportment. And one of my very close colleagues who has written considerably on nursing says every nursing act is an ethical act, as clinical judgment can never be separated from moral judgment in any situation. So now I'd like to just move on to nursing's code of conduct. We have the rules of professional conduct as developed province by province. Every province has their own regulatory body, and sometimes their professional body is sometimes the same, or there can be two different bodies. We also have a national organization called the Canadian Nursing Association, as well as we belong to the International Council of Nurses. The OIQ in Quebec, the Quebec Order of Nurses, is our regulatory body that controls who is admitted into the profession, to what extent they're able to pass licensing. They oversee the disciplinary standards of professional practice and protection of the public. And there are the Registered Nurses Association of Ontario publishes best practice guidelines, but it's the code of ethics that I want to take a few moments, and this is published by the Canadian Nursing Associations. Now, nursing and ethics, Nightingale talked about this, and she talked about that nursing required individuals of the highest moral character. Until then, the people who weren't nurses before Nightingale founded the modern nursing really were of less moral character. So she made a special point in pointing out the moral character that was needed to be called a nurse. And she writes a lot about this person should not be called herself a nurse, but she talks about integrity, compassion, humility, ability to observe. And Barbara Carper, who in 1978 described the different types of knowing that was required to a nurse, one of them was what she called ethics. An ethical comportment is basically asking the question, is this right? Is this responsible? And we know that there's moral ethical knowledge that is derived from theory and experience, and it's needed for clinical decision-making and ensuring the highest standard of care. And it's knowledge that guides what to attend to and how to direct, how to act. So the impetus for developing a code of ethics in nursing it started with first the welfare of nurses, then the regulation of the profession, and then the accreditation of which schools of nursing met the standards. And later it evolved into the protection of the public. So the first code of ethics, remember Nightingale wrote Notes on Nursing, which sets down what nursing is about in 1860. So the American Nursing Association writes its first code of ethics in 1896. And in 1954, the Canadian Nursing adopts the International Council of Nurses Code as its first code of ethics. But in 1980, it starts developing its own code of ethics. And this code of ethics has been revised 6 times. The last revision was 2017. So why do we need a code of ethics? This is what is written in the Canadian Nurses Association Code of Ethics. As for registered nurses, it's a statement of the ethical values of nurses and of nurses' commitment to persons with healthcare needs and persons receiving care. The code is both aspirational and regulatory. It is an aspirational document designed to inform everyone about the ethical values and subsequent responsibilities and endeavors of nurses. It is also a regulatory tool in that nursing in Canada is a self-regulating profession, and thus nurses are bound to a code of ethics as part of a regulatory process in order to protect and serve the public. Who is the code meant for and what? The code provides guidance for ethical relationships, behavior, and decision-making, and is used in conjunction with professional standards, best practice, research, laws, and regulations that guides practice. It provides guidance for nurses working through the ethical challenges that arise in practice with people, with persons receiving care, and with colleagues in nursing and other health care professions. The code is intended for nurses in all contexts and domains of practice, whether it be at clinical, education, administration, and research and policy, and at all levels of decision makings. The code is developed by nurses for nurses, and it is a means for self-evaluation, feedback, and peer review, and is a basis for advocacy. The code also serves as an ethical basis from which nurses can advocate for quality practice environments that support the delivery of safe, compassionate, competent, and ethical care. And we often see that nurses are witness to unethical practices and have often been whistleblowers to alert people when they feel that there is a violation and a breach of ethical practice by colleagues as well as other nurses, as well as medical colleagues or anyone else. The code is revised periodically to ensure that it is attuned to the needs of nurses by reflecting changes in social values and conditions and the public and any changes in the healthcare system. So we know that nurses are, as somebody once said, patient safety. Nurses are the last line of defense to protect patients. So what's the intersection between nursing and halacha? So Bruce, my husband, did a little bit of research on this, and he selected nursing interventions in the Torah and Talmud. I won't mention all of them because of the time, but a midwife was called a hachama, which means a wise woman, a hachama. Examples are Sifra and Pua. 2 Hebrew midwives who refused Pharaoh's orders to kill Hebrew males. In fact, it was because of them that Moses was saved, and that's why we're all here today. And I won't repeat the second one because it's been mentioned, but there are 2 terms used for healers in the Talmud. One is lov, which refers to a physician, and the other is tofali, which refers to a male nurse. And Jewish ethics, I think we have talked a little bit about this. The sanctity of life is a paramount principle. People are considered responsible and stewards of their own bodies, and that's why we are not and I think that this has been very nicely covered. People are responsible for their own health and for their own healing. And the relief of suffering is as important as the duty to care, and doing good is a major goal, as is doing no harm. And community concerns are important in Judaism, but when it comes to an individual's health, the individual concerns takes precedent over the community. And while health of the community is an important concept, the primary goal of healthcare workers is to secure the maximum resources for the individual patient. So I want to talk a little bit about my Jewish influences that have shaped strengths-based nursing. So my vision is how we're going to humanize healthcare through compassionate, knowledgeable, strengths-based nursing and healthcare. And as I said, this approach is resonating with many and is gaining traction. I just tell you very quickly about it. It's a value-driven philosophy on discovering and developing people's strengths to optimize health, healing, and functioning. Our current medical model is one of a deficit, focusing on what's not working, what's missing, rather than what is working, what people do best. As SBNH is about how one shows up in all situations. It is a way of being and a way of doing, and it is and it can guide clinicians, leaders, and educators. In fact, we are just mounting a whole program to train leaders in SBNH, and it is founded on principles of person-centered care, empowerment, relationships, and innate capacities for health and healing. It requires of those who are practicing this way a sense of curiosity and self-reflection in order to be open and to get to know their patients and families as based on courage and self-efficacy. So just to tell you what led to my own, how strengths-based nursing really reflects who I am and where I come from, it really comes from my own family upbringing. I come from a family that was very steeped in Jewish practices. My parents really focused on respect, tolerance, dignity, integrity. My family was. My father always said the most important thing was always being a good person and doing the right thing, even though the right thing might be very difficult. I came from a family that was well respected in the community, the Richlers, and whenever I would speak to somebody and tell them who I was, because I had my maiden name, people, my family's good name really carried forth. And we were really the family that was truly Shomer Shabbos and really quite steeped in Jewish ethics and Jewish values. I also have part of my understanding of what patients need and how they need it was my own experience with illness. My father was quite a sick man, and but he never defined himself by his illness, nor let his illness limit what he did. And at that time, nurses came often to our house when he had his bouts of illness. And I really saw the power of nursing. And at the age of 5, I had decided that nursing was my calling. My dad, on his tombstone, he died at a very young age, at 54. On my dad's tombstone, it summarizes who he was. He was a lover of God, a very spiritual religious man, but he also was a lover of mankind. And it was those two aspects of reverence for God and also reverence for his fellow man that really defined who I became and my belief system. I also was educated. I had Spanish and Portuguese. I attended Talmud Torah, Herzliya. We were the first class to occupy St. Kevin. We had been at Chevra Kadisha until it moved to the Spanish and Portuguese, attached to the Spanish and Portuguese. And I went to Camp Ramah. And in my family, there was a tremendous love and commitment to learning. Learning and education were the things that were valued. Money was not valued. It was learning and love and commitment to learning and growth and development. So my take-home messages are that patients and families need knowledgeable, compassionate, skilled nurses and physicians for health and healing. Nursing and medicine have different roles. Nursing has a well-developed code of ethics to guide nurses in all of their roles and in every setting. Nursing ethical comportment is at the heart of nursing, and Judeo-Christian values are embodied by nurses and embedded in nursing's ethos, and strengths-based nursing is anchored in Jewish values.
Great. Thank you. Thank you, Dr. Gottlieb. As I said, for the other speakers, I wish we would have time to ask you questions now, but I think we really will move on to our final speaker, who is Rabbi Barak Hetsroni. Rabbi Hetsroni was born in Israel, and he moved to Canada at the age of 23 after 3.5 years in the Israeli army. He came to Canada for the purpose of medical school, of attending medical school, but he ended up as a rabbi. So we're the beneficiaries of that. He's also a certified chaplain, and he serves as the spiritual advisor and rabbi at the Jewish General Hospital for the past 4 years. And with that, I'll give the floor to Rabbi Hetsroni.
Good evening, everyone. Just want to confirm that you can hear me well.
Yes, we can hear you. Will you be needing to show slides?
No. I chose this time not to prepare slides, rather to share certain stories or certain medical ethics questions that came here in the hospital. Less to discuss what my role here as a hospital, a spiritual care advisor, or as a rabbi, rather to simply dive into the water and give a few stories. All the stories are all related and will connect to one point that I wanted to bring today. This point is, I chose this point because of a certain government procedure that came during the pandemic, and that is the prioritization of patients. Who should be coming into the hospital, who should be receiving one care or another, who should be, in case we only have X amount of rooms, who should we treat first, who should we be treating second, and to an extent of who should be withdrawn from care. So all of this really brings us to one point of how much should we, one point that I would like to focus on today, and that is how much should we fight for a person's life. We understand that there is a value of life. We can add on to this to this value of life many other things, such as quality of life, the age of a person, how much is he capable from his beginning? Is he a person that is capable of doing everything like a regular person, or like most people? And how does halacha look at it? So maybe I'll start with a story that I had yesterday. I sometimes work on call at the Children's Hospital as well. In the Jewish hospital, I'm here full time, but there are times that I'm on call in the Children's Hospital. So a case that I had yesterday, last afternoon, evening, I was called, and it's interesting. This is one of the big differences between an adult hospital and the Children's Hospital. The way that I see it is that whenever it's a sunny day in an adult hospital, usually emergency room will be empty. You'll have no cases. For some reason, no one is sick. For some reason, everybody's healthy. Everything is beautiful until the evening. And when the evening comes, suddenly everyone remembers they're sick. Children's Hospital, it's just the other way around. When it's summer, you know that kids are outside, kids are playing, and you know that emergency room will be more occupied. So yesterday was a case of a 5-year-old. We call this it's a code 1010, that it's a bicycle versus a car with the child. The child wore a helmet, but still got a concussion, had to be brought to the hospital. And as we know, well, I said that everything I will speak will be different. It will be the same point from different points of view. So we know that many times, especially if it's towards end of life, but also with sicknesses, small things, there's a certain aspect of denial, either from the patient or from his family. So this patient, a 5-year-old, came yesterday with an ambulance and the parents, and she needed to be treated right away. We could see the doctors could see signs that she's not properly communicating. Neurology decided that she probably has, will not go into all the medical details, but she had blood in her brain. It had to be properly treated and right away. And the parents were in a certain denial of, what do you mean? She was talking to us a bit later, and she wore a helmet. We paid a lot of money for the helmet. It's a good helmet. And in a way, we understand that they wanted to gain their comfort or a certain understanding that everything is okay. But on the other hand, the doctor saw that something else is happening. In this case, a similar case took place in Israel a few years ago with it was a young girl that fell from the stairs in her house. They took her to the hospital. Same thing. They saw that she has blood in her brain, and they needed to perform emergency surgery. As they started preparing the little girl, this was about 2 hours after she fell. And her mother suddenly came in, rushing, and stopped everyone and said, "What are you talking about? I'm a registered nurse, and everything was okay with my daughter right after she fell. Don't touch her. I know who my daughter is. I know how she behaves. I know this behavior. She has nothing. I know how to treat her. Please go away. Don't touch my daughter. I do not give you permission to do anything on my daughter." And here comes a question of, the doctors see clearly that this daughter needs to have an emergency surgery. On the other hand, they need to get an approval of the mother. But if they won't, then if the daughter will survive it, she will no longer be able to do anything for the rest of her life, or there's a great chance that she will no longer be able to do anything in her life. So we understand that a person's life matter, and they take first priority. But what happens if it's a minor, and what happens with the mother? So in this case over there in Israel, what happened was that the mother was forcibly taken out, was placed in a place where she can not do anything. The daughter was operated successfully and returned to normal life. But the question later came to the rabbis. The doctors were religious doctors, or at least some of them, and halacha would clearly say in such a case that if you know that it's possible to save a person's life, if you have a great chance of saving a person's life, then even in spite of the fact that you have someone else that will be against it, that would not like this procedure to take place, then his opinion is nullified in comparison to the reality that we see, which is she has to be operated. And the same was done yesterday. Although the parents were in a certain denial, the daughter was operated, and thank God everything is okay with her. But this is one example of a certain medical ethics question that might come in conjunction with halakha. The second one is for also the pain of a patient. We know that if we're talking about quality of life, so there is quality of life that a person goes through in his life. However, there are certain procedures or certain treatments that are painful for the patient. One of the examples was a case that we had here in the hospital. Sadly, these are questions that do come every once in a while. Those are questions that it's not the first time that we see such a question. An older person that needs to go through dialysis, and he says, "Look, it's painful. I do not want to go through dialysis anymore. Enough is enough. It's too painful for me. Yes, I know what the hashlachot are. What will happen if I will not go through this procedure. And still, I would like to go through these consequences and not to go through this painful process on a daily basis or a weekly basis. In this case, halacha will be somewhere in the middle. If a person is really in tremendous suffering, if it's possible to numb the place, many times it's done with cream, with emla cream, or in other ways to prevent him from this suffering, it's one thing. But if a person has multiple issues such as cancer and diabetes and dementia, then in such a case there is no obligation to let him go through suffering. Whatever it is that I'm sharing now, the answers that I'm sharing are very, very general, very broad. Each and every case has to be looked at into the tiniest little details before an answer is given. However, this is a general answer. On the other hand, the same case we had here about 2 weeks ago, an older person, he was in his mid-90s, and he clearly said to his family, no matter, he was a Holocaust survivor, and as a young person, young child, the Nazis in Archibald would force him to take the bodies and put them in the fire. And he swore when he was a child that he would live to his last breath. And when he was sick, when he was old, he told his family, look, I know that when it will be time for me to go, or before, I might be in the hospital, and the procedures that I might have to go through, or the treatment might be painful ones. However, I don't mind going through any pain that exists for one more breath of life. I don't care what it means. I don't care how much I will cry. I don't care how painful it will be. I would like to stay here for each and every breath that I can. And when the medical staff heard it, he said it well enough before he was really, really sick, and that's what they did. And even when there was no hope of they didn't do anything to try to revive him, but when he needed an IV and they could no longer find his vein, they asked for a special permission to have radiology come and make a minor surgery to have a small PICC line with some liquids and some salts, something to keep him alive for a few more days. So this is an example of a person, again, life. How much should we do for life if there is the pain of the patient in the center? Another case is what do we do when a person might hurt the patient, not now, but in the future. Not now and not in the future medically, but it might, the fact that we are going to do a certain treatment on him now, a surgery, in this case, in this case that I'm going to bring, it won't hurt his medical condition, but it might put him in big danger later. The example is a person that tried to smuggle things through the border, and he did it by swallowing it. He got caught, and I don't understand exactly how they weren't able to wait until it will pass through the stomach and come out, because there was a great risk that it will all open in his stomach. And the doctors were afraid for his health, for his life. And the police said, no, this is a part of our evidence. We want you to operate, to perform a surgery, an emergency surgery right now, because this is our evidence. And the patient himself said, I prefer that it will open in my stomach. Let me die. I do not want to continue living if I will get caught. In such a case, there is, you can see a contradiction between, in a way, a contradiction between halakha and really what the medical field would say, or what the law said. So the law here said that it has to be opened, yes, for his health, but a lot for what he's trying to smuggle, and this can be an actual proof. Halakha would say that we're obligated to do this surgery although he does not want it. Why? Just like the first case, we have almost 100% certainty that he will live, he will survive, and he will continue his life normally from the medical point of view. And if we'll keep it in, there is a great risk that he will die, and therefore we're obligated to perform the surgery. If it's just to catch him, or this will be the proof in court, halakha would say that it's not a good enough reason to hurt a person's body. I'm sorry, I know that we're late and we ran late, so I don't know if I have more time or if we should cut it here. So just let me know, and I'll go according to that.
No, I think you still have a couple of minutes.
Okay.
Please.
Okay, no problem. Okay, so another example. I'll try to finish with this example, and also a story, because our time is very limited. It's a case that I had here in the hospital about 4 months ago. I would say an older lady. She was, I think, 98 years old. She came here. She had she needed to go through a certain procedure in her heart. She was here. She went through 2 procedures. Everything was okay. Everything was fine. But she was kept in observation. She was here for about 3 months in our heart unit. At a certain point, after 3 months, she got the COVID. And she went up to the COVID floor. Her heart was fine, but she had a problem now with the COVID, and then it became hard on her to breathe. And then she told me, Rabbi, that's it. I had my life. Everything is good. That's it. Now, medically, it was possible. She was on a little bit of oxygen, and we could see that she deteriorates a little bit, which means that she started being in need of more and more oxygen. And the question was, should she be intubated in case we need it? Should she be given more and more medications? And now I'm asking now, according to halacha, how much should we fight for this person's life? If he says, that's it, I do not want anymore, are we obligated to try and intubate this individual? So I'll say what happened with this particular case. In this particular case, the intubation process itself would, chas v'shalom, be the cause of death for such a fragile old person. So intubation was not an option. In her particular case, it was an incredible story, because she clearly came and said, Rabbi, please, I want you to say the vidui with me. And I told her, are you sure you might come out of it? Last year we had a 101-year-old COVID patient in the first wave that made it and went out of the hospital at the age of 101. She celebrated Erev Pesach 101. So this older lady told me, no, I want you to say the vidui with me. I say the vidui with her. I say all the final prayers with her. A day or 2 later, I come and she marks like this with her finger. She tells me, Rabbi, look. And she points towards the windows. And I said, probably she sees something. I asked her, do you want the water, or is there anything outside? She tells me, no, not Rabbi. No, not this. Look there. And then I see the board. She has a board. Every patient has a board in his room. And on the board, it says, congratulations, the 99th birthday was today. And she tells me, Rabbi, I want you to sing happy birthday for me. I finished my role in this life. I want you to sing happy birthday for me. And it's a 99-year-old woman, a Holocaust survivor, pure as can be. And she wants me to sing happy birthday for her. And I sang, and she was so happy. And she told me, Rabbi, I'm leaving and you're leaving. Goodbye. Maybe 2 hours later, she passed away. But you could see that to me, as a person that works in the hospital, it was something that a person that went through, sorry to say it, Gehenom in the World War with the Nazis. I'm the one that's supposed to sing happy birthday and make such a person happy. It's a big zchut, it's a big privilege, and I think it comes together with what it says that you should come from a shiva house. You should come out happy, not chas v'shalom happy because of what happened there, because what happened there really shows you, puts you in the right track to show you, whoa, this is the reality as we know it at the end for every person. But I'm still here. I can still do everything I want. I can still create. I can still make. I can still do everything. So this should make you happy. So when I came out of this visit back then, it was a very, very special moment for me. So this is a little bit about really, I only did a few of the cases that I had here, but maybe another time. I think the guideline that I had in all of this, that we have life and we have real life and we have life in this world. On one hand, Allah tells us that we should do everything we can to let a person live one more second, one more minute in this world. On the other hand, we know that going to the next world is also a part of life, and we're not allowed to intervene and stop this process. Yeah, and I think this is the point. Try to use every second that we have here.
Thank you, Rabbi Hetsroni. A good way to conclude the formal session. I know the hour is late. However, our guest speakers and our speakers are all still here, and there may be some really burning questions that you should have the opportunity to ask them while they are here. So what I will ask, please, if you have a question, please go raise your hand, and to raise your hand, you click on the participants and you can raise your hand. But please make it a question. Please do not make it a comment or a discussion, but just a 1 or 2 sentence question, and that's it. So I see that Albert Herskovich has raised his hand. So please go ahead, Albert. And unmute yourself.
Thank you, Ronnie. My question is addressed to Dr. Archibald or Rabbi Hetsroni. When you have a patient fairly sick, an elderly patient, who has signed a document or might not have signed a document, but expressed a desire for assistance in, I don't want to call it living, what is it? Medical assistance to pass on. But that person is not fully cognizant of their actions. How is the medical profession or the rabbis or the people there, the team, in a position to assess the level of cognizance of that person? That person may be so badly in pain that they don't know what they're doing and they just say anything. And they say, I want to end my life. How is the medical team able to assess that situation?
Can I take a first pass at this?
Sure.
So the term is medical assistance in dying in Canadian legislation. So a patient who wishes to take advantage of this option has to make an application. And the person who makes the application has to be cognizant of the application and of the consequences. So they have to be, it's a bit like a will. In a sense, you have to be of sound mind when you make this application. The application is a process. There are social workers involved. There are medical professionals involved, including physicians, etc. And they have to decide whether or not the application for medical assistance dying is receivable or not. If in fact, in the institutional setting, I gave you the example of the CHLSD of Émile Léger, for instance. That institution has a committee which decides whether the application is receivable or not. There has to be a 10-day reflection period for the person to actually decide, do I really want this? And then, as with the example of the Truchon death scene, which I described to you, the attending physician at that particular point in time has to ask the patient if he or she actually wants to proceed with the procedure. And so they have to provide quote, informed consent. And if informed consent is not given, then you cannot move ahead with the procedure. Okay? So it could be that, according to the law, it could be that the person who asked the question is the attending physician, but in fact, nurse practitioners in Quebec are allowed to do the same thing. And so therefore, the nurse practitioner can determine whether or not informed consent is given. If they determine that informed consent has been given, the person is immense competence, then the procedure can continue. And so that is what under Spanish law would refer to as active euthanasia. I tried to summarize that quickly for you. Rabbi Nassim, maybe you want to add to that.
Well, regarding the actual diagnosis of whether a person wants it or not, it's something that at the end of the day, we cannot really make the decision for him. There are many, many implications to such a decision, which will come later, such as organ donation, way of burial, if it requires a signature of higher hierarchy, if a Jewish doctor can sign such a document, what happens with the neshama later, many of those implications. I know that I had a few of those cases, and Judaism looks at it on one hand very seriously. On the other hand, in today's society, if a person chas v'shalom commits suicide, unlike olden days where he would not be buried or buried in a certain different area and so on, we do understand that we're always trying to find a reason for him to do it. And one of them is he wasn't 100% himself. And that's why he did it. On the other, so over here, we need to make sure that a person is 100% himself, that he did it because he knows it's him. So it's a real contradiction within the Jewish law. Yeah. And so we're trying to avoid it. But
that's why Rambam talks about contradictions.
Yeah.
And that's what your role is as a rabbi, to help us resolve these contradictions.
Right. But I can tell you one thing, that when I had some of those discussions with patients here, the last one of them was a little bit before Pesach, between Purim to Pesach. It was a from person that went through tremendous suffering, really tremendous suffering, and none of us should go through any of it. Usually what is recommended is to try to give the individual, the patient, as much sedative as possible, that he will not literally won't feel anything. And in spite of the fact that this itself might bring to his end or even quicker, as long as it's not one shot that does it, rather slowly, halacha permits it in certain cases. Definitely the kavanah, the intention is not for the individual to lose his life. But in this particular case, and in previous cases as well, when I was able to have a serious discussion with the person, and I knew that there might be an influence, then I would explain in a serious way, a loving, caring, serious way, that once you get up there is no way to come back. It's a one-way ticket. As long as you're here, you're in the hands of God. Once you get there, it might sound scary a little bit. It might, but at the end of the day, this is what it is. So I know that it made an impact on this individual. They did make an impact, and it's not for a purpose of scaring anyone, but it's a reality. And since he called me as a rabbi to ask me what my opinion is about it, then I had to share with him. I would not go to any individual and start lecturing or preaching him my 2 cents on it, but that's what I answered in this particular case.
Okay, thank you very much. Now we have a question from Dr. Gottlieb.
No, it's not a question. It's really a comment to continue this discussion, because this is causing an awful lot of anxiety and distress on the part of nurses. I have been in meetings where head nurses have to go because such a thing is happening on their floor, and the nurses are truly upset and very distressed by having to either witness this or be party to it. I've especially some nurses who are extremely religious. Like I had a long conversation with a nurse who was asked to participate in an abortion. She's Roman Catholic. She said she just could not do it. She came with a solution that she would not participate, but she would help comfort the patient during this procedure. So this is an area that's causing a lot of distress to the healthcare providers. And I think we need to address that too. Those who are there to comfort and to, and to preserve life, how are we responding to them?
Thank you very much. I don't see any other hands up for questions. So I'll just conclude, first of all, by thanking the speakers, really wonderful speakers, everyone different, from a different perspective.
Ronnie, could I ask one question?
I'll think about it, Jim.
I want to go back to the scene which I described to you of Mr. Truchon's passing away. And I described the scene because it was a piece of reality. But I wanted to know if Dr. Gottlieb thinks that the actual scene was what she called a healing environment, or whether she wouldn't qualify that as a healing environment. What's your take on that?
Well, it depends from whose perspective. I think it, it depends on from whose perspective. It's really a conflict of values. If we believe people have a right to self-determination, to what extent we support that, versus, I think there is a clash of values, and the question is, I can't really answer that. How do we describe healing environments? Healing environments are it depends what the issue is. Healing is if it's for physical environment versus healing to provide comfort and a sense of peace when somebody is passing. Did that environment create a sense of peace and creates a calmness, an inside and internal calmness within that person? Did they achieve that? Because we often see that, patients who have delirium, even palliative care, and we know that they are going to pass soon, but to what extent do we provide comfort to them, and do we say things that really reduce their level of anxiety and stress? To me, that would be a healing environment. So it depends what the criteria of a healing environment is, depending upon different situations and different circumstances.
Okay, thank you. Again, thanks so much to our speakers. And I'll just conclude by mentioning that the next session, which takes place on June the 7th, is on the administration professions, so management and accounting. So with that, I wish you all a good night. Thank you very, very much for attending, everyone. And we look forward to seeing you at the next session.